Hello and welcome to the second part of the male reproductive pathology lecture. In this lecture, I'm going to look at male endocrine disorders, the different causes of hypogonadism, kind of explore Klinefelter syndrome a little bit more depth, talk about andropause and male infertility. So I'm going to focus on male hypogonadism. Female hypogonadism I've mentioned a bit, and we're going to talk in depth about that with the in the female reproductive section with estrogen. But remember that androgens can be low in females as well, and we think that can lead to sexual dysfunction of various types, as well as more metabolic problems. So I'm not going to focus on that as much here. So male hypogonadism, by definition, is diminished function of the testes, and that's going to lead to diminished hormone biosynthesis, so decreased androgens, specifically testosterone, but also androstenedione as well. Adrenal DHEA, kind of independent of this, so it can still provide a pool of androgens in the body. But again, with a really taxed adrenal system, that DHEA might be lower than necessary. But usually we just focus on the testes and we find there's low testosterone and androstenedione. Now, hypogonadism can be primary, meaning it's a problem in the testes, or secondary, we also call that central, and that's a problem in the pituitary or hypothalamus. So with primary hypogonadism, it's also known by hypergonadotropic hypogonadism. Remember the gonadotropins, LH, FSH, if the testes are not putting out enough testosterone through negative feedback, the LH, FSH levels should go up. So we're going to see hypergonadotropic hypogonadism here. And the cause of this is impaired response of the gonads to the gonadotropins, or a problem in the testes themselves where we're not producing the androgens properly. The treatment is usually with hormone replacement therapy. So the classic kind of examples of this could be either congenital or acquired. So the congenital forms would be things like chromosomal abnormalities leading to testicular dysfunction, and the most classic here would be Klinefelter syndrome, and that's having two or more X chromosomes in a male. So the genotype is 47XSY, or actually 48XXXY. That's a more severe form. Male Turner syndrome, also called Noonan syndrome, is 46XY, and then XX gonadal dysgenesis or mosaicism would be other congenital chromosomal abnormalities that would lead to lower or ineffective testicular activity. There could be defects genetically in some of the androgen synthesis enzymes, like 17-alpha hydroxylase deficiency, and so forth. These would be all different variants of congenital adrenal hyperplasia as well. So we're going to see decrease in adrenal hormone synthesis too. Gonadotropin resistance would be essentially mutations in the gonadotropin receptors, so for LH and FSH. So Latex cell hypoplasia would be from LH insensitivity, and then general LH FSH resistance. These are going to be much more rare, but I put them on the list just for completion. We can also have acquired forms of primary hypogonadism, and those are going to be probably more commonly encountered in the clinic. So that would be things like testicular disorders, torsion, vanishing testes, cryptorchidism, where again the testes doesn't properly descend through development into the scrotal sac, infections like STDs and orchitis from mumps. Those would all be acquired reasons for hypogonadism. Different drugs, chemotherapy, obviously anti-androgens, opioids, high doses of alcohol can all suppress testicular function. And then toxins, and this is where we're finding there's a whole slew of endocrine disruptors in the environment. Many of these fat-soluble toxins, pesticides, whatnot, are actually anti-androgen, pro-estrogen. So they have an estrogenic effect and they suppress the androgenic activity. So that is a real problem. And especially in the testes, we see a lot of these just over time accumulate. And that's why we think worldwide we're seeing a pretty drastic decrease in fertility in men, especially in industrialized countries, because of the bioaccumulation of these compounds. Probably the one you're going to hear about most commonly clinically would be what's called adult Latex cell failure, or andropause. And that's just with time, the testes start to put out less androgens. And that could be from a variety of factors, from diminished blood flow, from endothelial dysfunction and cardiovascular disease. Again, that could be from the presence of different toxins and endocrine disruptors. We're not sure why, but we see the androgens definitely decrease with age, and I'll talk about that here shortly. So that's primary hypogonadism. Secondary would be, again, a problem in the hypothalamus or pituitary, and that would be impaired secretion of FSH and LH. And the treatment here would generally be with GnRH agonists or the hormone replacement therapy. So congenitally, we can have decreased GnRH, and that would decrease FSH and LH. And examples of this would be Kallmann syndrome. That's about 50% of cases of this. And that's where, again, from the olfactory bulb, the GnRH secreting neurons don't migrate into the hypothalamus properly. And this one's associated with loss of smell, anosmia. GnRH insensitivity and Charge syndrome, these are also examples of congenital decreased GnRH. Acquired would be from brain or pituitary tumors like hyperprolactinemia. Remember, prolactin will suppress GnRH. Head trauma, pituitary collapse, and ischemia. Certain drugs, and then metabolic states like advanced diabetes and hemochromatosis, and this causes iron deposition in the pituitary, damaging the pituitary secretion. So a lot of these causes are what we saw with pituitary disorders and hypopituitarism specifically. So that would be the typical causes of secondary hypogonadism. And then you can also have defects in the androgen action, and that's generally androgen receptor insensitivity. This is going to be a lot less common than the other two classes here, but I, again, put this on the list for completion. So that's an overview of primary and secondary hypogonadism. Let me look at a couple of these disorders in a little bit more detail here. So the first one here is Klinefelter syndrome, and this is a cause of primary hypogonadism. And this is a set of symptoms that result from two or more X chromosomes in males. And the typical presentation would be a shorter stature with small testes, so hypogonadism and infertility. It occurs in about 1 to 500 to 1 in 1,000 live male births. About 10% of cases are found by prenatal diagnosis, and about 2/3 of cases are never recognized. So a lot of times Klinefelter can be very mildly expressed, and many people don't even know that they have this extra X chromosome, and it usually doesn't result in too many problems. So it's in the more severe cases, phenotypic expressions, that we tend to think about this clinically. The symptoms will be more severe if there's a third X chromosome. So not just XXY, but XXXY. And typically this is not inherited, so we think it's some sort of congenital chromosomal damage that occurs. And the diagnosis is primarily to do a karyotype on lymphocytes. So that's a fairly simple test. They can look at the chromosomes in lymphocytes, and they can count the number of chromosomes and see how many X chromosomes there are present. The clinical presentation, the low androgen levels can be really subtle, again, might not be noticed until puberty, if at all. But typically things like gynecomastia, decreased muscle mass, decreased facial and body hair would be expressions of this. Broader hips, longer arms and legs, more gangly looking. Increased risk of deep vein thrombosis, osteoporosis, and different autoimmune disorders. And then usually intelligence and brain function is normal. There have been reported in the literature some learning and reading impairments that can occur in Klinefelter. So that's something to kind of assess clinically. And then we think there's a normal life expectancy with Klinefelter syndrome. This should be differentiated from Kallmann syndrome, as I mentioned in the previous slide. It's called Fragile X syndrome and Marfan syndrome, and this can be assisted through genetic testing, etc., if that needs to be done. The treatment typically is, if there's very low levels of testosterone, especially during puberty, that would be to give testosterone replacement therapy. if there's a male and the couple is infertile and it's because of male infertility, because the male has inadequate testicular function, then there's different assisted reproductive technology that can be used. There can be cosmetic treatments like breast removal if that's a concern, and then having adequate psychosocial support. So this is, an example with Klinefelter of essentially a genetic male who has a lot of intersex characteristics. So there's more feminizing characteristics. So again, it's going to express differently in different males, and people will have different, sort of approaches to it and different concerns about it. Again, in the majority, 2/3, it's never diagnosed, it's never really suspected, and it's not really an issue. Again, it comes out sometimes with, especially at puberty, the lack of the male sexual development might be pretty obvious then, but also with infertility, that might be a concern as well. So that is Klinefelter syndrome. Just wanted to kind of point out this picture below. This would be kind of a typical phenotypic expression of Klinefelter. More common, and again, this has received a lot of attention in the literature. There's a lot of, especially in functional medicine, but also in the natural products industry, a lot of interest in what's called andropause or adult Latex cell failure. This is essentially the male menopause. It typically begins around the age of 40, 45 when we start to see testosterone levels really plummet. So testosterone levels are usually highest between 20 and 30 in males, and then they go down subsequently with each decade. So at the age of 70 or so, we're about half the levels of testosterone as a 20 or 30-year-old. And, just like with female menopause, the question is this really a disorder or is this part of natural aging? And so that's where it gets controversial. Does this need treatment at all? Or is this something that is part of a natural process? So usually we see with the testosterone declines an increase in sex hormone binding globulin as well. So that, again, will result in less free testosterone being available to the tissues. We think that one of the primary drivers is microvascular insufficiency to the testes, again from endothelial dysfunction, and that could be the result of poor dietary habits, lack of exercise, the typical factors that increase atherosclerotic cardiovascular disease would all increase hypogonadism there, nutrient deficiencies as well. Again, this is controversial. It's actually not recognized by the World Health Organization as a condition, but it's talked a lot about in the popular literature especially. It sometimes goes by the name of low T syndrome. And again, in Chinese medicine, this is often called kidney yang deficiency. Typically, the levels of the gonadotropins will fluctuate, so that can be difficult to use gonadotropins to assess this. At age 80, the testosterone levels are decreased by about 50% in men. And we often see that with the testosterone lowering that actually estrogen levels start to go up. So the ratio of testosterone to estradiol decreases. Many causes, just normal aging, again, poor diet, excess alcohol, I should say smoking as well, cigarette smoking, chronic illness in general, lack of sleep, lack of sexual activity. It's a hypothesis for why some men, just over time, they're not getting the same hormonal stimulation, so they essentially, their testes stop producing as much testosterone. And should really put exercise on here, so lack of adequate exercise, and then having increased physical or psychological stressors and trauma. All of these are contributing factors. Again, if you kind of look at the list of factors that increase the risk of atherosclerotic cardiovascular disease, it's really the same as what induces hypogonadism. The clinical features vary, but things like low libido, depression, anxiety, fatigue, poor memory, loss of muscle mass and strength, maybe myalgias, vasomotor instability like palpitations, even hot flashes and diaphoresis in men. In bone, we might see osteopenia, osteoporosis. In terms of palpitations, typically it'd be things like PVCs, but it could actually be AFib. And there's an interesting correlation with atrial fibrillation in older men with low testosterone. And correcting the testosterone actually decreases the AFib. So it shows how the heart really is dependent on all these other endocrine factors for proper function. Cardiometabolically, low testosterone, as I mentioned previously, can increase the risk for diabetes, increase cardiovascular disease by increasing the LDL, as well as all of the pro-atherogenic factors, inflammation, etc. Again, increase AFib risk and then endothelial dysfunction. We might see erectile dysfunction, but remember there are other causes of that. So there could be vascular, psychogenic, neurogenic causes that should be investigated clinically. We talked about that in the anatomy and physiology lecture. And then there can be a decrease in testicular volume and gynecomastia from the decreased testosterone estradiol ratio. The assessment of this would be to look for the clinical signs and symptoms. Again, a decision will have to be made as to kind of does therapy need to be initiated or not. I'll talk about that here in just a second. The labs you might want to look at for would be CBC, might show evidence of microcytic anemia. Again, we'd have to rule out other causes like a GI bleed, cancer, etc., that might be contributing to that. Measuring testosterone, again, usually in the morning, 8 to 11 a.m. Total testosterone levels are usually under 300 nanograms per deciliter. I recently had a patient who has all these signs and symptoms. He has AFib. He actually has a valvular disorder as well. And his testosterone, total testosterone, is around 20. So extremely low. And we did a free testosterone, and that correlated with that, quite low. And so he's been a patient we've been working on to try to get that level up with the different therapies here. Usually if we're going to do a total testosterone, again, that test usually comes with a sex hormone binding globulin level to see if it's really elevated. And then we can also check for salivary testosterone. Serum LH could be helpful, not typically measured. Usually it's high normal or slightly high. It's not reliable, and many men actually show decreased LH with age, so that's not necessarily an indicator of andropause. Semen analysis is only rarely done. That would be maybe for a younger man who shows signs of andropause, who is concerned about fertility, but usually we're going to see a decrease or absent sperm. And then DEXA scan could be helpful in males over 65 to assess bone mineral density to be sure that's not an issue. That's more commonly done in females, but does have a role here if we're concerned about that in a male. For the treatment, we're going to follow the therapeutic order. Again, I typically start at level 1, level 2 for andropause, to support the salutogenic factors, and jump to level 3 only if those factors are not appropriate or are not effective and we really see a need for androgen replacement. So level 1 would be, again, diet, exercise. I talked about some of those in the previous video. Sleep hygiene, mindfulness, reducing cigarette smoking, alcohol reduction or cessation. And then level 2 would be supporting the neuroendocrine terrain. So using micronutrients like zinc, copper, making sure that ratio was established, magnesium, B vitamins, herbal therapy with phytoandrogens or stimulant adaptogens. Again, we might need to look at the nervines or other treatments there depending on the case. Using acumoxotherapy and then potentially hydrotherapy. All of these would be level 2 interventions. And then level 3 would be to jump to androgen replacement therapy. Again, I usually start with DHEA there first, 10 to 20 milligrams in a male, and try that for 3 to 6 months and see what happens with the androgen levels with that. And if that still doesn't raise the testosterone, and again, if there's still a need for it, then we can jump to usually the gel form of testosterone or an implant would be possible therapies for that. Okay, so that's a little bit on andropause. So a fairly common concern of patients presenting to integrative medicine practices, Chinese medicine or naturopathy, etc., is infertility. With infertility, it can be either infertility due to the male or in the female. About 40 to 50% of cases of infertility in a couple are due to male infertility, and this refers to a male's inability to cause pregnancy in a fertile female. It affects about 7% of all men globally, and unfortunately the number is increasing, and we think that's because of the accumulation of all these environmental factors which are inhibiting normal testicular function. We can classify male infertility, and this is helpful clinically to think of it this way, as either pre-testicular, testicular, or post-testicular. So pre-testicular obviously would be conditions that impede the hormone support of the testes. And that would be problems of the gonadotropins, for example. So that would be like the hypogonadotropic hypogonadism. We went through some of those already. Celiac disease, different drugs, again, alcohol, tobacco smoking, exercise, and this would be more from damage to the blood flow to the testes from excessive bicycle riding or horseback riding. Bike riding in particular, the saddle for the bicycle can really impede blood flow to the testes, and that can cause a real problem with adequate androgen secretion. DNA damage, that can be inherited, and then different epigenetic factors. So these would be pre-testicular causes of infertility. Testicular causes would be problems in the testes themselves where they can't produce adequate hormones. And that could be, this again would be commonly associated with hypergonadotropic hypogonadism, so primary hypogonadism. And that could be structural from varicoceles. That's a pretty common cause, about 40% of all testicular causes of testicular dysfunction. Hydroceles and cryptorchidism. Genetic, we looked at Klinefelter syndrome already. Tumors like seminomas, testicular cancer, trauma again, radiation, infections, especially mumps orchitis, but also malaria can cause this. And then up to 30% of cases are just idiopathic. And then finally, post-testicular would be defects of the genital tract in ejaculation. And that would be like vas deferens obstruction, or in cystic fibrosis, there's actually a lack of vas deferens. Infections, epididymitis or prostatitis, retrograde ejaculation into the bladder, ejaculatory duct dysfunction, hypospadias, impotence, all of these would result in poor semen output through the ejaculatory duct system. So those are post-testicular causes of male infertility. How do we assess this clinically? Well, the first is just to do a complete history and physical exam, including a full genital exam, as we've discussed. A semen analysis is crucial, and usually we need 2, ideally 3 of these, and that's where a male has to be sent to a special center, where again we need to analyze the semen within an hour microscopically to assess the function of the sperm. And I went through all the criteria for that in the anatomy and physiology lecture. Want to do a CBC, CMP, TSH to check for general metabolic function. Want to measure a total, and usually also eventually, if that's low, a free testosterone or a salivary testosterone. Importantly, you need to check prolactin to be sure elevated prolactin is not causing a suppression of gonadotropins. And then especially LH measurements could be helpful. Maybe estradiol if we suspect there's too much aromatization of the androgens. And then I put DHE as a question mark. That's typically not measured in the conventional workups for male infertility, but it could be an additional factor to look at. Genetic testing again for Klinefelter or other chromosomal problems, cystic fibrosis might all be important as well. And then getting a scrotal ultrasound can be important just for checking for any evidence of varicoceles or anything else that could be causing testicular dysfunction. So that would be the assessment for male infertility. Again, the treatment would follow the therapeutic order. We try to address the causative factors. And here we're probably going to need a specialist referral if what we do is not really effective within a few months. So we want to address level 1, essentially everything I talked about with hypogonadism. Level 2, again, looking at the HPG axis with the testes, considering insulin resistance and melatonin, as well as looking at general organ system function like the liver and so forth. And then for therapies, for male infertility due to the hypogonadotropic hypogonadism, that's where LH FSH therapies, clomiphene, testosterone therapy has actually been found to be fairly ineffective, interestingly, for male infertility, and then potentially aromatase inhibitors. I put all question marks next to these because it's not quite known how well these work. So that's where I usually just refer to a fertility specialist who can work through the latest findings and kind of work with that. But definitely with level 1, level 2 support, that can be effective in many, many cases. So that's definitely a good place to start. And then we can make appropriate referrals. If again, within maybe 6 months, those therapies have failed with a couple to, to conceive, then we can make the appropriate referrals. So that is male infertility, and that wraps it up for a general discussion of endocrine disorders. In the next video series, I'll focus specifically on prostate disorders, and we'll look at BPH, prostatitis, and prostate cancer.